So this is case number one. So we collect our data. So this is the suitability. We collect our photographs: incisal view at rest, dynamic smiling, full face retracted. So we have our measurements. So we know that whether I am increasing the length of the teeth, I am doing some soft tissue work. This is all important in our data collection. So we do our smile design so that I know where to put the teeth in the right place. You see here from the top picture, the incisal length when the patient is at rest is good. So we can't make the teeth too longer. So we need to take the gums up. So then we do soft tissue surgery. Then we start to do our digital wax up, and I collect my EMG data. Now, when we look at the data here, you will notice reds on most of the things. So half is red and half is blue. So the red is telling us that there is an issue with the muscles. So in this top right-hand corner of the picture, you will notice 55. That is giving us an overall score. So the one reason I like TDAN so much is that it simplifies your data collection. You're not reading the micro EMG activity. What the data does it all for you. It actually gives you numbers so you can see, and it also tells you what is normal. So you see here, the impact data in this patient should be 85%. His impact data is half. So he is at 50% activity level. So the patient has some problems. And this also relates to his teeth because he has less teeth. We do our facial scanning, we do our planning, and we also collect our motion data. So he's a type 2 motion on the right and a type 3 on the left. If I redesign the teeth, does that improve his motion? Well, let's see. This is his cycle in and cycle out pathways. So we design the wax up using motion data. We place the teeth in the right place. He had some missing teeth as well. So this is all the planning. My cycle in pathways are all similar. We use the data that we've collected to design the wax up. So here we are designing function. And the teeth are all designed for mastication. This is then transferred into a mock-up. So I can test this new occlusal scheme, and then I transfer this into his finals. He's had implants, so I've placed implants on him, and I've done full mouth restorations. Now look at the design of the restorations. All the cuspal inclines in cycle in are the same, which is what we want. It's perfect. These are the anterior restorations. And this is his motion now. So is he starting to chew better now that I've designed his teeth? Look at how well he moves now, much more smoothly. So he's gone from this to this. When we look at the data collection now, look at how I've designed the restoration cycle in, cycle out. So we've now given good data to the muscles. This is the motion, right and left. Look at the cycle in and cycle out pathways. They have changed. And look at his motion. You see that the top picture is his motion at the start and the bottom is the motion at the end. So we have a different cuspal inclination, a different cycle in and cycle out pathways. These are the restorations at the end and the smile. But what about the EMG data? Look what happened to all of his data. His impact data, if we look at this slide, everything improved. His health, his muscle health improved. His impact data went into the normal range. His asymmetry index, which is this bottom right one, is now perfectly symmetrical. It's 0.84%, and that's slight prevalence to the right. So If we design the teeth combined with the muscle data, we see that the patient gets better. We see the temporalis activity is within normal, his barycenter is posterior, which we like. We like the contacts to be on the posterior teeth, so for chewing, we like that. If you look at his barycenter at the start, 7.4%. He was at a 10th, so because he had missing teeth at the back. So you see what happens to the muscles when we change the teeth. The muscles get better.